Today lesson is I'm going to teach you how to deliver a solid presentation during rounds. Now, this is also part of how you can stand out during your USCE. Previously, I discussed about how to think like an attending, and another thing is how to present confidently. So this is part of how you can stand out during your USCE. You see, there are preference between doctors. Everybody is different. Some doctors like presentation this way or that way. So it's actually very, very variable. But at least I can group it into two types of presentation, which is academic and non-academic. So these are the difference. So in the academic settings, like usually you're gonna do this in the settings of a university hospital program, for example. They are more thorough, they help learning, and they help build clinical reasoning. We're going to show you what it's like in the academic presentation. And non-academic presentation would be presentation that you do in usually in a community hospital, where it's pretty short. It gets to the point. It basically focus on management. In non-academic, they just want to manage patients. That's the whole point. Just want to manage patients, get to the point, get to the things that I really need to know, and then we'll make a decisions and then move on with it. Non-academic is also the way to present when you call for consults, by the way. So even in academic settings, when you call for consult and then tell them you want to get to the point, focus on management, focus on the things that they want to focus on. So non-academic type of presentation also useful for the academic institution. So let's go through the academic presentation. So the first step is to provide age, gender, chief complaint, and leave the past medical history. Now, this is the big thing. You leave the past medical history alone. In the non-academic presentation, you will include the past medical history. Why? Because sometimes the past medical history kind of give away the diagnosis, it give away the clinical reasoning. It's important to leave the past medical history and they just mention the chief complaint. However, you still need to mention the past medical history if it's impossible for them to figure out without telling the past medical history. For example, HIV. That's a game changer, right? If you don't know a patient has HIV, it's going to be very hard for you to tell that this is cryptococcal meningitis, for example, or a PJP pneumonia. It's going to be very, very difficult, right? Organ transplant is another example. So you will provide the past medical history if it's impossible to tell assessment and plan without it. But if there is a past medical history, for example, like had diverticulitis before, came in with the lower abdominal pain. That's kind of like a giveaway. So we don't want that in the academic settings. If we want to try to help people to learn and build clinical reasoning, you just leave those type of past medical history alone. Then you go through the symptoms. Now, my mnemonic is DFP and Licora. That's what I like. All right. Everybody has their own mnemonic. This is my mnemonic. I'm just sharing with you. Duration, frequency, progression, and then Licora is the location, intensity, quality, onset, radiation, aggravating, alleviating, associated symptoms. This works for really any symptoms. Let's say nausea. Okay, then you're gonna start to ask like how long you have nausea, how often you have it. Let's say in a week. Is it every day? Do you think it's getting worse? Do you think it's getting better? Okay, intensity of nausea, you can still ask. Quality doesn't really fit. So usually you go with the aggravating and alleviating factor. Like, is there anything that's going to make it worse? Is there anything that makes it better? And then associated symptoms. Do you actually vomit? Do you have any fever? Do you have night sweat, etc.? All right. Now, Licora specifically will be very useful for pain. Any pain. Let's say abdominal pain. Easy one, right? So where is the abdominal pain? Is it the epigastric? Is it the lower? What's the intensity from 0 to 10? How do you describe the pain? When did you start having the pain? Does it radiate anywhere? To the back, to the groin, to anywhere? All right. Anything makes it better, anything makes it worse. And if there's any associated symptoms, now there you put the fever, nausea, vomiting, diarrhea, constipation, etc. So it will work with pretty much anything. But here's the thing. I'm gonna give you this one very important tips that you should not miss. Out of these questions, the most important one is the onset. Most important is the onset, the chronology. And that will be the first thing that you should ask. So you don't get too distracted too much. For example, the patient said, look, I haven't been feeling very well. I have the chest discomfort. So the next question is not, uh, do you feel that the pain is radiating to the back? No, don't ask that. Anything makes the pain better? No, don't ask that. The next question is always, how long do you have it? All right. So it's always time. It's always onset. That is really the highest hierarchy. If even if you don't get really anything else, yeah, if- because sometimes the patient is a poor historian. Sometimes it's very hard for us to get like a very full proper questions. If the patient has metabolic encephalopathy, the family doesn't really know anything. How can you really ask the progression, the duration, if it's radiating, how they describe it? There's no way, right? So if there's anything that you want to know, it's the onset chronology. All right. Now, after you completed the description of the symptoms, you need to provide the additional symptoms and the negative symptoms. These are what we call the review of system. Now, I don't want you to go review of system and then you go top to bottom. No blurry vision, no double vision, and then no sore throat. And so that is a waste of time. That is a poor presentation. Now, you do the review of system in a more relevant way. So you need to know the pertinent negatives and pertinent positives. This is actually where you actually show if you actually understand the differential diagnosis, because your pertinent negatives, pertinent positive would have to anchor to some form of the differential diagnosis. Let's do chest pain. It's very easy. What's the differential diagnosis of chest pain? Straightforward, right? Especially if it's acute chest pain. It's going to be coronary artery disease. It's going to be a pulmonary embolism. It could be GERD, could be diffuse esophageal spasm, it could be herpes zoster. So now you're gonna put on the pertinent negatives. What are going to be the thing that will rule those out? Maybe pleuritic chest pain, maybe the nausea, vomiting, maybe the rash, problem with swallowing, association with food. So those are the things that's going to be kind of like important to add. It's kind of show the attending that you thought of these differential diagnoses. So you add these type of questions that rule out some of the stuff using your history. All right. Then you're gonna provide the ED course or the ED chronology. What happened in the emergency room? This one is quite straightforward. You just go basically find the story, what happened in emergency room. They give this fluids or some sort and they start something. Okay, and tell them what actually happened there. If there is nothing that important, you can skip this part actually. Then you go to meds, allergy, social, family. Usually you don't really mention meds. Why? Because telling them the medications, also tell them the past medical history. It's kind of like a giveaway. Allergies is usually not really relevant, but the one that I really like is the social part. You're not gonna tell them all the full social history, but these are the important one. Okay, smoke, alcohol, substance, and living situation. At least those stuff. It's kind of tell the attending that you know about the patient, right? Now the physical exam, when you go for vitals, give them the numbers. Don't give them hemodynamically stable. That's too short. I would say blood pressure is 130/75 on initial presentation. Just give them the numbers on the initial presentation. Then give the number for heart rate, temperature, etc. All right. And then you mentioned the physical exam from top to bottom. Just mention the relevant one. So, for example, in patient with heart disease, like a chest pain, the relevant one would be lung exam, like the heart exam, and lifetime imaging. I would usually always mention CBC and CMP, even though it is normal. I would say the CBC and CMP unremarkable. If there's only one, two things that are abnormal, I'm just gonna say CBC is normal, except hemoglobin of 10.5. Or the CMP is pretty much unremarkable, except potassium 3.2. You can do the other way around. That works too. Potassium 3.2, the rest of CMP are normal. Okay. And then, of course, the trend, if there's a changes. And pertinent negatives always need to be mentioned, like EKG negative, or troponin 2 times negative, or lipase negative. These things that's going to alter differential diagnosis or affect the management would need to be mentioned. Now, if you're doing a presentation after a call, then probably there is some changes overnight. This is the time to describe it. So after you finish with live imaging, you're gonna mention if there's any changes. We think this, but apparently there's this happened. So what happened, right? After that, you provide your assessment and plan for the chief complaint, and then all the other problems. You have to list all the problems in the order of acuity and severity. And that's pretty much it. Now I'm gonna give you an example. All right, I'm gonna give you a very straightforward example. 56-year-old male presented to the ED with chest discomfort. Shortness of breath started 6 days prior to admission. He was maneuvering a ladder when he first started feeling the discomfort. Ignored it and then waited out. 3 days later, he felt it again when he was mowing the lawn. So you see there is a clear chronology there, right? Patient denies pain. It's more of pressure with shortness of breath, not completely relieved by rest, but it did get somewhat better. It lasted for a couple of hours. Now then we move on to the pertinent negative, denies palpitation, like swelling, heartburn, no rashes. So try to rule out some zoster there, right? No issue with swallowing, no pain with deep breathing. He lives at home alone, is non-smoker, does not drink alcohol, does not use any substance. So that's the social part. No medication part because the medications kind of give it away. His vitals are blood pressure with this. You mentioned the number. He is awake and alert, very comfortable, not obese, no jugular vein distension, lungs are clear, heart sounds normal. Okay. Chest discomfort and not reproducible on palpations. So we try to rule out what? Costochondritis there, right? Abdomen exam normal, no edema on the legs, and there is no rash. So it tries to rule out the zoster. So looking at this, it's clear that how we try to rule out some stuff based on the history and physical exam. Okay. Even this alone is already good enough. It showed that presenter knows what he's doing, basically. CBC, CMP unremarkable, X-ray chest negative for any acuity. EKG shows sinus rhythm with right bundle branch block, unchanged compared to 6 months ago. Troponin done 2 times negative. So that's pretty much it, right, for the lab and imaging. And then the overnight, comfortable overnight without any issue. And the assessment and plan, we put as unstable angina. Patient started on aspirin 325, nitro-PRN, maintain on telemetry. Resume his home medications. Now we can mention the medication because we already gave away what's going on. Toprol, Brilinta, aspirin, Crestor, and patient is planned for stress test EKG and cardiology is consulted. That's it. Straightforward case, really gets the job done. So that is academic presentation. Now, what if we do non-academic presentation? What's gonna be sounds like? Gonna sounds like this. Very short. 56-year-old male, past medical history, coronary artery disease, got PCI, stent, 2022, comes with chest discomfort, shortness of breath 6 days prior to admission, worsened 3 days ago, chest pain-free, hemodynamic stable, negative troponin, kg baseline, no change, right bundle branch block, other labs are looked good. So he has unstable angina. We resume home meds, maintain on tele. We'll do a stress test and put cardio consult. Short. But we kind of give away of what's pretty much going on with the past medical history, and then they say chest pain, right? So it's already leaning toward that. And there was like really no curveball or anything that sounds weird. We don't put anything. We already just jump toward this is what we're gonna do. All right. So this is really focused on management, and this is also the way you're gonna call for cardio consult, for example. This really gets job done. You can kind of like depict of what's actually going on with the patient. Okay, he is stable, he is good. We're just gonna do stress test, and then we're gonna reassess. Now, some things to keep in mind. If the patient has more than one complaints, you wanna go with the first complaint first, describe everything, go through the pertinent negatives, then you go on the second complaint, and then you go normally, and then once you get to the end, you're gonna have an assessment and plan for problem one, and then you assess assessment plan for problem two, and then you go in order for acuity and severity. Now, sometimes patient come in not a mystery diagnosis, kind of like obvious. Hemoglobin is 4, patient's anemic. My doctor told me to come get a transfusion. Then it's an anemia, right? For this one, you just go along with the chronology of what happened, what actually lead into the hospitalization. That's completely fine, and then you just follow the order like usual. So let's summarize. So this is how we do the presentation in order. You mentioned the age, gender, chief complaint without past medical history for the non-academic, right? Describe the symptoms, onset and chronology being the most important one. Do not miss the onset and chronology. Okay. Then you mentioned the pertinent negatives, pertinent positive associated symptoms if there's any. Provide ED course if there is anything that's important and altering the differential diagnosis or management. Mention the social living situation. I would at least mention smoking, alcohol, substance use, and where the patient lives and with who. Physical exam, mention vitals with numbers top to bottom, pertinent, positive, and negative. With labs imaging, focus on pertinent, positive, negative as well. Don't forget to group them together. LFTs, normal, coax, normal. Don't say albumin 3.5 or albumin normal, bilirubin normal. It's too long. Just group them together. Make it nicer. Uh, Give an update if there is any updates for overnight, something changed, some dramatical change. Maybe the patient's blood pressure drop, needs to go to ICU. And then you put assessment plan in order of acuity and severity. And that's pretty much it. That's how you give the solid presentation. Of course, the key is practice, practice, practice. This is a skill. Fortunately, this is a skill. I give you the way to do it, but in the end, when it's a skill, you just have to practice. I can't just tell you how to drive the car. I can give you the theory of how to drive the car, but and at the end of the day, you need to drive the car yourself. All right. So that's it for today's lesson. I'll see you again in the next